Thank you and good afternoon. About 300,000 new HIV infections occurred in Asia and the Pacific in 2019. 98% of new adult infections were among key populations and their partners, over a quarter among young people. Stigma is an important contributor to the continuing epidemic in Asia and the Pacific and to the rise in new infections among key populations. This is because stigma has a myriad of damaging effects, including increasing vulnerability to HIV and reducing access to HIV prevention, testing, and treatment services. Pre-exposure prophylaxis, or PrEP, is an HIV prevention tool that has been shown to be highly efficacious, has been associated with population-level decreases in new HIV infections when rolled out at scale in places like Scotland, Australia, England, and the US, and is empowering for many users, resulting in improvements to sexual well-being, self-confidence, and reduced shame about condomless sex. While there has been an acceleration, the number of people who use PrEP has fallen short of the global commitment to have 3 million people on PrEP by 2020. Asia and the Pacific accounts for less than 10% of new PrEP users, and this number is not proportional to HIV incidence, prevalence, or country population size, and is not at a sufficient scale to achieve the population-level reductions in new HIV infections that we need. One of the most basic determinants of PrEP uptake and continuing use is availability and access. In Asia and the Pacific, while more and more countries have introduced PrEP, for example, through demonstration programs, private sector, and as part of donor-sponsored or country-sponsored rollout, or combinations of the above, PrEP is not yet widely available. Pre-exposure prophylaxis, or PrEP, sits at that intersection of several closely related stigmas, including HIV stigma, key population stigma, and fundamentally sexual stigma. PrEP and PrEP services are particularly vulnerable to the effects of stigma. Before PrEP, prevention of the sexual transmission of HIV involved limiting sexual activity and/or the numbers of partners, consistent condom use. With PrEP, these restrictions are no longer strictly necessary, but the widely held belief that PrEP causes people to have more risky sex means that despite being arguably more effective than, for example, condoms, PrEP is viewed as a less honorable prevention method. And the overwhelmingly negative assumptions about the personal life and behaviors of someone who wants to take, is taking, or has taken PrEP can have a profound effect on willingness to start, continue, or stop. We know that stigma is already disproportionately affecting marginalized and disempowered individuals and populations, such as key populations, and that many members of key populations may also benefit from or be eligible for access to PrEP. And these stigmas are not just coming from one direction, they're perpetuated at multiple levels, from self-stigma to healthcare workers, decision makers, and the broader community. Stigmas against PrEP uptake coming from all of these different areas impede access to and the scale up of PrEP by influencing behaviors. Influencing determinants of uptake, such as risk perception, risk disclosure, and health-seeking behaviors, influencing structural factors such as PrEP policies, inclusion by national governments or insurance policies into the range of prevention options available, decisions on funding, and even at a clinic level, it influences things as simple as whether a provider will offer PrEP to someone who needs it or will refuse to offer PrEP to someone who has requested it. Because of this, multidimensional strategies are needed, including establishing enabling policy environments, ensuring that the needs and preferences of potential users are embedded, adopting and promoting models of service delivery and care that are acceptable, accessible, and equitable, addressing the awareness, attitudes, and knowledge, not just of individuals, but also providers and the broader community, and changing broader structures that perpetuate stigma. PrEP clinical guidelines and policies must avoid further stigmatizing populations and PrEP users. Guidelines that use identity independent of other factors as an eligibility criterion may unintentionally stigmatize key populations as irresponsible, promiscuous, or immoral, or stigmatize PrEP as something that only a stigmatized population could or should use. We have seen this in the real world. Since 2015, WHO has recommended PrEP for people at substantial risk as an additional HIV prevention choice. The importance of this is that it was an enabling recommendation and was different to previous recommendations in that it wasn't population specific. A number of recent guidelines locally have taken a similar approach, including Nepal, Philippines, and Laos PREDR, and others. And subsequent guidance on event-driven PrEP, for example, provides greater flexibility to people who need PrEP to support more effective use and to embed it as an additional prevention option. So taking this a step further and considering eligibility and risk screening tools, both at a population level in PrEP policy as well as program, but also at a clinic, there is growing evidence that risk-centered approaches disempower individuals, are less effective, and perpetuate stigma. And indeed, there's mixed evidence for the utility of risk screening tools generally. The biggest danger of a risk screening tool is that they reinforce barriers to PrEP and focus on morality. And this results in excluding people from PrEP who would otherwise benefit from it. We know that overwhelmingly the people who ask for PrEP are also people who would benefit from it, even if their risk is not disclosed. And this is why WHO and most guidelines in our region recommend PrEP for anyone who wants it. So reframing this eligibility assessment in clinics as a conversation tool or a PrEP counseling tool is critical. And it's important to use non-judgmental questions to help find the right prevention tool, which may or may not be PrEP. Certainly, fear of risk compensation at either a programmatic or policy level or a clinic level should never be used to stop PrEP being provided. PrEP is about preventing HIV. Effective use is another theme that also needs to be considered within this paradigm. And effective use is about taking PrEP as directed when it's needed and thinking that people need to take PrEP in the same way that people need to take treatment contributes to stigma and a misconception that PrEP users are irresponsible, which is damaging. So in Asia and the Pacific, civil society organizations and key population-friendly clinics are preferred by many people who would benefit from PrEP. The best known of these is in Thailand, and these key population-led health services have provided innovative service delivery models that have been reimagined and tailored to other unique contexts across our region, from Myanmar to Vietnam, the Philippines, and other places. Virtual services have gained increasing importance due to COVID, and these include e-counseling and telehealth, but they've also been utilized very effectively to create virtual, non-judgmental settings and protect confidentiality. They are increasingly important going forward. And it's crucial that we prioritize and diversify access to PrEP using a variety of service delivery methods and not to rely on traditional methods which may inadvertently restrict PrEP use. Key population-led health services such as those in Thailand are ideal to offer stigma-free PrEP services, filling gaps typically left by traditional HIV services. And these focus on across 4 domains: accessibility, availability, acceptability, and quality. Services provided by key populations are identified by the community itself and are therefore needs-based, demand-driven, client-centered, and delivered by trained and qualified providers who are often members of key populations themselves. And you can see this principle in action in the Tangerine Clinic for transgender women. I want to emphasize the continuous quality improvement that happens at the clinic, and also that there's been a dramatic increase in uptake. The contribution of online services to that and the shift from a risk reduction approach to gain-framed messaging have likely all contributed. And the contribution of key population-led services to scale up in Thailand has been profound. They account for over half of all PrEP users. Key population-led or friendly clinics also feature in other countries. In Australia, key population-led testing clinics are a complementary approach that help reach communities that may be less engaged with mainstream services, but would still benefit from testing and PrEP. These serve as central points for information about PrEP, conduct assessments for PrEP suitability, and have robust referral pathways to partner in key population-friendly sexual health clinics. The cost of PrEP is another critical policy and programmatic concern. We know that PrEP costs are a significant driver of uptake, and there should not be a choice between HIV prevention and other essentials. There is an increasing recognition regionally that PrEP is a public health good rather than a lifestyle choice, and this change in framing is critical. Places like Australia and New Zealand have embedded PrEP within their systems and is subsidised by the government. Thailand has included PrEP under the NHSO from 2019, and Vietnam has a co-payment system where it is largely subsidised. At a smaller scale, PrEP is provided for free under limited demonstration trials, but as we move to scaling up PrEP, funding and costing remain a critical concern. And particularly what we've seen is that in countries where access is predominantly via a private sector, pricing can vary dramatically and is often unaffordable for the most vulnerable, and this has limited uptake and rollout. One of the most obvious and recognizable, although arguably also most incredibly effective approaches, involves promotional campaigns to reframe conversations about PrEP, and these are particularly important when they're public-facing. Australia and much of the region did not have the same stigma against PrEP that places like the US did, and this has a lot to do with proactive messaging and early community engagement. Launched in January this year, the new Take Me campaign by the civil society organisation ACON aims to encourage people to have conversations about PrEP, aims to normalise PrEP, and normalise the use of different options like daily and event-driven PrEP as equally valid depending on the preferences and frequency of condomless sex. Similarly, gain-framing messaging is a central theme of Thailand's PrEP in the City campaign. This was Asia's first trans-Pacific PrEP campaign and was launched in September last year. It features 4 transgender women and is designed by, produced by, and for trans women, aiming to empower trans women to take control of their HIV status. It conveys the experiences of taking PrEP in daily life and is gain-framing, refocusing that conversation away from risk, and it is incredibly important in terms of the conversation that it inspires by being public-facing and in the offline space. And these kinds of positive, empowering, dare I say, sexy and fun campaigns are an increasing trend within our region, and that's something that we should all highly promote. And these approaches are just some of those available, but are more important than ever as we look towards the future and towards ending HIV transmission. The UNAIDS targets for 2025 focus on putting people at the center of the HIV response and call for the scale-up of a core set of evidence-based HIV services, which includes PrEP as part of combination prevention. And achieving the targets requires an openness to innovation and a commitment to expedite not only the technological breakthroughs such as PrEP, but it critically requires us to focus on the removal of barriers such as stigma with practical and concerted efforts if we have any hope of success. And so in conclusion, stigma remains a key barrier to PrEP and PrEP services. Overcoming stigma requires an investment and a conscious action at all levels of PrEP programming, from policy development and financing to service delivery to community awareness raising. To realize the potential of PrEP as an empowering and effective tool for reducing HIV transmission on a population scale, we must adopt approaches and innovations that increase availability, access, and acceptability. We must look at high quality, convenience, choice, community-led, demedicalization, virtual space and online interventions, equitable financing, gain framing, and focus away from risk. And we must ensure that these efforts are broader than PrEP, but also tackle related stigmas and their legal frameworks. Thank you.